Welcome to the AISN podcast, where we talk to the operators, founders, and clinicians who are actually building the future of healthcare and aesthetics, not just theorizing about it. I am Geet, founder of AISN Partners, and today's guest is someone with one of the most genuinely multidimensional backgrounds I have come across. Dr. Ryan is an emergency physician, double boarded, including psychiatry, holds an MBA, and is the CEO of MediMorph, rapidly expanding integrative aesthetics network currently operating across Ohio, Kentucky, Florida, and Colorado, with a vision to scale up to 60 to 100 clinics. Before this, he built what is now the third largest mental health and substance use network in the United States, from 0 to 90 clinics. He knows what scaling looks like, what the operational chaos feels like, and he has opinions about AI that you don't hear from most people in this space. Dr. Ryan, welcome.
Thank you. Appreciate the time today.
Most physicians who start a business are doing it as a side project. You built a 90 clinic national network. That's a different species of ambition. What did you learn building that mental health company from scratch that you're now applying to what you're building at MediMorph?
Sure. I think it's important to call out that that wasn't necessarily the intention. I was actually in San Diego last week receiving an achievement award for national policy work in substance use and mental health. And I was talking to a friend of mine who is executive at another large mental health and substance use network. And he just said, "Hey, man, this is amazing. Like, you affected the lives of millions." And my response to him by text was, it needed to be done, So I've never really taken on things with the perspective other than when I recognize, because I do a lot of mathematics and epidemiology in medicine, when I realize that the gap between good care and where we're at is the problem, that's when you start to begin to think to scale. Right. So when we started that particular organization in Cincinnati, I was just a frustrated emergency physician. I couldn't get help for patients or friends or family that had mental health and substance use issues. The standard of care was non-scientific. It was actually quite tragic. There was, abuse of patients in regards to, body brokering in Florida. It just was a gigantic mess, particularly misaligned with what was the opioid crisis. And so we focused a fair bit on that. But we just started one clinic in, the center of Cincinnati, which was between the two practices, two emergency practices where I was at Jewish Hospital and the University of Cincinnati. And we started with a fairly simple concept. We should follow the science, which was actually well known in the mental health addiction space. What was the evidence? What should we do for folks? We delivered compassionate biopsychosocial care. That's the model of care we developed over a decade. Biopsychosocial meaning the medical, whether it be of internal medicine or psychiatry physician, the psychological with therapy as appropriate, and the social supports that were key and critical to the delivery of care. And we did it at the lowest cost possible for the patients. And like I said, we did it with compassion and concern for their situation. Turns out, if you follow the science and you take good care of people, there's an actually, substantial need for that. And of course, 10 years ago, at the height of the opioid crisis, there was a definitive need. And so we followed that rubric of, compassionate, evidence-based care, and met the needs. And we did some wonderful things. We were able to bend the mortality curve in the state of Ohio, which is wild to talk about. My policy award was based on the fact that we were able to shift Medicare and DEA rules and state rules to align with the model of care that was necessary. So the scaling journey was what I would describe was somewhat unintentional. It was trying to take good care of patients, as I trained to do many years ago. And it was the realization that there was a monstrous gap.
I think it always starts with a personal reason and a gap, and then it turns to something much bigger than you could ever imagine.
Yep. Lessons. It's harder than you think it is. Number one, it's easy to scale things that are simplistic and not great medical care. We've seen that in the past 30 years multiple times, and now with telehealth, we see it a lot. It turns out that what I'll describe is, slinging weight loss drugs through an app is not actually great care. And so it's much harder to do things at scale that are good. And this is a human services business. We're taking care of people. And so it's not a technology. In fact, some of the founders of the other organization and I have joked that we should have gone into tech or finance or something like that, because it's just, you can deliver a great technological product at scale much easier than human services. Other lessons learned were, as a founder, as you grow, and I learned this from a a sage advice giver on our board there. You have to reinvent yourself every year or two. The chief medical officer of a 5-site clinic network is nothing like being the 25, 50. It's a totally different paradigm. And the other part is when you're in a field that is not well trained to a standard of care, you have to build it. All of that experience is reflected now into this anti-aging platform that we're building. And I think it's a little easier this time.
Mhm.
I have to figure everything out on the fly, but it's going to still be the challenge. And the differential challenge that I talk about is that in the mental health and addiction space, we actually knew what to do. There was 50 plus years evidence that just wasn't being followed. Dr. Kang says we translated science to practice, but we had this anti-aging space is much different in the development. We're still learning what to do.
Mhm.
The concept that you deliver wellness care or hormone and weight loss and other nutritional programs in what has typically been historically a med spa addressing only the surface of the person's aging issues. 5 years ago, that was a novel concept, which I knew was absolutely necessary because it turns out that your skin's not great if your hormones aren't great and like 50 other examples. So this is going to be a different journey because we're going to have to rapidly evaluate changing science, including the peptide, the whole
Research.
yeah. And I'm excited actually. I launched a project yesterday to build an AI evidence evaluation engine with some colleagues so that we're not, chasing the latest Instagram post on whether it be injection therapies, lasers, or,
Yeah, rightly said. And you mentioned something that stuck with me, that managing aging from cell to surface of the skin. Most of the industry is still talking about Botox and fillers. So you are talking about a fundamentally different clinical framework. What is the anti-aging platform you're actually building, and why does it matter that it's different?
So to be clear, this was my wife's idea.
Mhm.
She's a bachelor's in nursing with a long history in cardiology and infection control. And 5 years ago, she wanted to get back into the workforce after her kids had grown up a little bit. And my only request was don't go back to the hospital and get killed. So she started in a small place that had some of these pieces, and I just saw it. If I have any special skills, it's a little bit of like forward vision and like seeing the matrix, as people say. And I said, well, this is different. This is 5+ years ago. This is different. And they're actually applying hormone therapy to their body contouring clients. So if you're doing M sculpt or cool sculpt as an example, and those two things are substantially more synergistic than just doing one or the other. Not surprisingly, in the past 5 years, most of the industry has figured that out, but it does bring a breadth of complexity to how do you coordinate those services and how do you sequence them and how are you evaluating the patient for their optimal outcomes, right? And I think it goes back to my previous gig, right? Is I looked at the whole person, biopsychosocial model, right? Thinking, what are all the needs of this person? And in hundreds of cases of seeing patients over the past 5 years or so, where I would look at the patient and I would know, you really actually need wellness. Then we have to have the services, machinery, products, whatever it is. We have to have well-trained clinicians in order to apply those methodologies. Both of those are very difficult. The training is long and complicated.
Yes.
Yeah, and so we're building a solid training platform to serve that. And it just like I said, I remember walking into a patient case not that long ago, where about a 40-ish year old woman wanted to do a particular treatment in regards to her muscle building, which we use M-Sculpt to do. And literally, without drawing her blood, which we did later, I could see that her estrogen testosterone were deficient. You can see it in the skin laxity. You can see it in the muscle structure. It's just not again, it takes years but as a physician, you get pretty good at these things and you just see the person and you're like, I think that fall.
Right.
Take a little history, normal practice. You take a little history, you talk to the patient, you do a physical exam, and you're just like, I think I know what's going on. And you back that up with blood work. And of course, good for her. We were able to ascertain the actual deficits and manage them. And so there's just, like I said, hundreds of thousands of examples that we know of where it is way better for the client or the patient to really be served comprehensively.
You mentioned earlier that it's easy to philosophize and hypothesize, but much harder to execute. You can psychologically map the entire customer journey, but executing it on the scale across multiple platforms is a problem. Where does that execution gap shows up in the aesthetics industry right now?
I think it's back to that comprehensive treatment plan, right? It's about doing a good history, physical, laboratory evaluation, needs analysis, and then talking to the patient about it. And it presents a couple of issues: sequencing of therapies that meet the patient's need, but also meet their budget. Like I joke with, some of our male patients, they're like, I just want to look, like Captain America. I'm like, we can probably do that, but it's going to be a sequencing of things that is necessary for you to follow my guidance on. Weight loss is a particularly important topic because of the fact that the clients, there's a general sense of faster is better, which I completely disagree with. With humans, we've done many things over the past 100 years in the United States with medicine, and never have I ever seen an example other than things like if you're having a heart attack, we should actually do a cath in 90 minutes. These kinds of things, are in trauma and emergency medicine, right? Like you don't need to delay bullet holes. Like otherwise, physiological management should be somewhere in the neighborhood of like lowest and effective dose, PM, speed, these kind of things. And with some of the newer medications coming out, the biggest topic they're talking about is how fast can you lose weight. That's not a great idea, actually. We've seen it with what I would say is summarily failed gastric bypass and other things that never did really address the biopsychosocial needs of the person. Ended up with all kinds of problems, overeating, the gastric bypass. Actually, one of the things that people don't really know is a lot of those patients end up with alcohol and substance use problems that didn't address their psychological, basically food and dopamine addiction. And so, yeah, probably I kind of landed in a weird spot where there's actually a lot of corollaries between hormone weight loss management and addiction because of the neurochemistry involved. So all of that to say, it's about like making sure you start basic medicine, good history, physical treatment plan, and then aligning with that patient's timing, their fears and concerns of whatever. If it's a laser therapy for resurfacing, managing those fears and concerns, and then being reasonable with their budget. It's all of those things together.
Keep all these protocols across the different locations in the same manner.
Yeah, that's exactly right.
And you said something about the technology also. Like anything that was good 6 months ago is now a problem. That's a brutal reality for operators trying to build a system in a rapidly changing AI landscape. How do you think about building infra that doesn't become obsolete before it's even deployed?
Yeah, I think iteration and increment is the way to think about it. So, I was reviewing an AI agent on a website or a practice that is excellent at answering questions. However, we need to be careful with AI giving medical advice. That is actually not a great plan yet. And also, what is the psychological acceptance? For those of us that work in technology, tend to lean more like, of course, everybody's going to want to use this app or this AI agent or whatever to talk to it. That is actually not true. Adoption of AI is still like sub 1% globally.
Healthcare.
Yeah, especially in healthcare, which is the key and critical. That also reflects to the why we do a hybrid in-person telehealth model. And so what we've seen with the telehealth only models, particularly those ones that are actually not even telehealth, they're just apps, is there are huge gaps. So they built these amazing systems to track, blood work and medication refills and whatever else. And what is lost is the human component. Turns out a whole lot of people, especially when you think about demographics, talking about 40 plus by and large, not always, treat younger patients than that too, but thinking through like what is their actual adoption and comfort with non-in-person services. So how do we hybridize that and look across the timeline of what is adoption going to look like? And how do we, to your point, not build antiquated systems that are out of date in 12 months? I think that has to do with structure basis of it. So a lot of our equated EMRs are built on things like, Excel 97, and they're
Right.
already bad 2 years ago before AI really took any grip on everything. But now they're obsolete. They're so far obsolete. And so when we look at the technology basis, we think, how malleable is this, right? Not scalable necessarily, but how malleable is this? And how do we look at the architecture and infrastructure and make sure that we're not behind? Now, there's a problem with that, in my opinion, because none of us know.
Yeah.
Not none of us. Maybe Elon knows, right? He's building Terafab now, which is an absolutely insane concept. So impressive. But how do we make sure, that we are not waiting for when we know it's correct, right? So as an organization, we're evaluating a whole new tech stack, from marketing to CRM to EMR. When is the kind of critical inflection point is what everybody's asking. When do you wait till there's a fully AI built EMR? Is that even correct? Isn't that the right way to do it? From an experience of doing health IT for 20 plus years, I've been through the ringer. I've seen paper charts to first time EMR implementation as a super user as a medical student, which was not a great idea. And for me, I got yelled at by all the residents who didn't want to transition to EMRs, but I was a technologist by background to some extent. And so it's really about just like trying to find that right window.
And I believe it's just having that conscious mindset of trying to build something which is usable, scalable, and something that will be helpful, and something that gives you what you're looking for now and will give you something that you're looking couple of months and couple of years from now.
That's the malleability piece, Keith.
That's
That's
the
what I'm
best.
thinking about. Yeah. As can't wait forever, right?
Mm.
But
Yeah.
also need to be conscientious.
Won't be perfect the first day, but yeah, it's incremental improvement that will matter.
Yeah. And remembering that all patient experience is on a bell curve. There's people
Mhm.
that don't ever want to talk to anybody. There's some measure of anonymity bias amongst the weight loss and hormone stuff. People are still embarrassed to talk about menopause, perimenopause, weight loss, etc.
Right.
But it's about building a platform that serves all those needs, understands that an AI agent may or may not be actually adopted by many people yet.
Mm.
When you look at our particular demographics, we don't think it's the best solution today. Me personally, I'm pretty tech forward, so like I'm happy to talk on an app, you know. But that's just we try not to. We have to try to not drink our own Kool Aid and be talking about TerraFab while Betty Smith, who's 63 and wants help, doesn't care. And I think that's a pretty big gap in the psychology of what we're analyzing as best practices.
And MediMorph's marketing mantra is build trust, address concern. You have staff with 20 to 25 years of experience, a residency level training program, real clinical depth that most med spa generally can't claim. How do you translate that depth into something a prospective patient actually feels before they walk in the door?
Yeah, I think that's the most difficult thing I'm dealing with right now. Is that so? My wife, and as an example, we were doing a certification review the other day, and her list is literally like this long. I mean, it's I don't know, 50. How do you let people know that? That's a lot of time and money she spent. Her patients know it when they see her because they come from all over the place. They come from other med spa
Mm.
clinics and they know it when they see her because, I mean, she deals with complex cases like autoimmune disease, people that still want to resurface their skin, that kind of stuff. Well, you can't just go to Vegas and learn about autoimmune disease and skin resurfacing. That's not reality. So we're working on talking about that. But I think because you're putting things in people's face or you know, addressing their deranged hormones, weight loss, whatever. These are sensitive topics, and the human ego is actually quite complicated. And so, we aspire to do. You think about all the forms of marketing. There's ads, short form videos, and I think one of the key components is going to be able to get out there and do a little bit of a MythBusters kind of situation, right? Because unique to this industry, I've never dealt with it before. There was a little bit of social media influence in the mental health and addiction space because as social media was developing from 15 to now, it's quite different, but there is a ridiculous amount of consumer confusion of what to do, the right face treatment, the right hormones, the right whatever. And I think that we at MediMorph aspire to kind of, really get out in the market and have these conversations. Simple examples, I've just seen so many of the wrong treatments on the face. What I describe as patient unfortunately they got whatever the practice had, not what they need, which is not good medicine.
Right. Need to match to the patient's need, not the other way around.
That's exactly right. Don't come in and tell them, "Hey, I'm gonna address your rosacea with microneedling," which is the wrong technology. It needs to be a laser. But we've seen this over and over again. They go somewhere, they have a master card, and they're like, "Absolutely, this will address your concern," which is bad medicine, bad practice, and in my book is unethical. Don't do that.
Mhm.
I did secret shopping with an entity for cool sculpting as an example, just to see. Well, I saw the salesperson, not a clinician, on a video. They don't know. They didn't look at my body. I don't need cool sculpting. I've done all of the things to keep myself in good shape. I couldn't possibly need cool sculpting. We'll put it that way. And they were like, absolutely, $3,600 or whatever the charge was. We're happy to take your credit card and deposit right now. And I was just like, you don't even know what you're talking about. You don't know who you're looking at. You didn't look at my body. These kind of things are actually pervasive in the market and really tragic. And I think, like I said, with weight loss, the key and critical is missing in a lot of the weight loss pieces is thinking comprehensively. Most people that need weight loss also have depleted hormones. Most of the telehealth practices out there don't address those two or more things that are necessary. And you see this huge whipsawing, right? They get on
Mm.
high dose, whatever. And whether it's a GLP or there's other, by the way, a lot of people don't even know, there's actually other medications
Mm.
completely reasonable for weight loss. You have a huge weight loss, right? Don't address any of their behavioral resistance training, gym kind of stuff. We do a free gym membership with a partnership through Planet Fitness. Don't address the whole person. And lo and behold, they lose 60 pounds, come off the GLP-1s and come right back. It pops out. In fact, worse, almost worse a lot. They sling back to gaining 70 or 80 pounds after the 60 they just lost. And in that situation, they're often already muscle mass loss, which is your active metabolic engine, and they've lost bone density, depending on their age, particularly females, perimenopause, menopausal. And just people aren't thinking. Take the person. And for me as a physician,
Mm.
at this point, 5-ish years, it's very frustrating to see the field,
Right.
some groups chasing dollars and not patient care.
Mm. Right, right. I can imagine that how difficult it is then when you see something like that happening and you feel like the whole system has gone and turned in a way that you can't imagine it to be.
Yeah, I think that there's big social constructs like the social media problem in the field, but there's also through many things, including our friends at Amazon, we've become a right now society. And I can't
Mm.
complain because if I want something to my house in the next 4 hours, I can get it. Physiology doesn't work that way. But I want this right now. I want to click an app and I want to lose weight. Well, that's a very unfortunate understanding by the consumer that right now is best.
Yeah. Sean, this has been a genuinely useful conversation, not just for the audience, but for the conversations that we are about to have. The thing that stand out to me is that you build the infra, the depth and expertise in the clinic that nobody else in aesthetics is, talking about